Hi everyone, welcome back. I'm going to finish the third part to the endocrine lecture, and in this one I am going to talk about alterations of the adrenal function, which is going to include only Cushing syndrome and Addison's disease. So let's start with Cushing syndrome / disease. So there's a Cushing syndrome and there's a Cushing's disease. So a Cushing's disease is something that happens where cortisol is secreted from the adrenal glands in large amounts. And syndrome, typically it refers to when somebody has Cushing's symptoms because we give them a medication, which is corticosteroid, and they go into this Cushing's syndrome. And all we have to do is stop this synthetic cortisol that we give them, or corticosteroids, and then they will go back to their normal state. A condition of excessive amounts of cortisol. Okay, first we talked about ADH, too much, too little. Then we talked about thyroid hormone, too much, too little. Now we're talking about cortisol, too much, too little. Again, compare and contrast. Causes iatrogenic from ingestion of corticosteroid medications. All right, just what I said, Cushing syndrome. Or they can have tumors of their pituitary gland or their adrenal gland, or they can have a problem with their hypothalamus. So any of those things can cause it, but the most common thing we see these days is Cushing syndrome. So let's take a look at their clinical manifestations. Cushing's syndrome, an increase in corticosteroid, which means they have an increase in cortisol, corticosteroid, an increase in mineralocorticoids, and the mineralocorticoid is aldosterone, sorry. So glucocorticoid, corticosteroid, cortisol, increase in mineralocorticoid, aldosterone. Increase in cortisol, increase in aldosterone. So think about what those two things are going to do, right? Obviously, people are on these corticosteroids to decrease inflammation. That's great. But with that comes multiple side effects the longer that they're on it. So if I'm holding on to, I have increased aldosterone and increased cortisol, I'm going to have increased sodium and water retention, hence hypertension. Sodium water retention, which is going to give me weight gain of adipose tissue, most particularly in the trunk, facial, and cervical areas that give them the moon face and that kind of hunchback, that buffalo hump. It's described as truncal or central obesity. They get that kind of look that you know about because of the fat, that kind of that adipose tissue that moves, that leaves from their arms and legs and leaves them skinny and deposits itself more in their trunk. So let's take a look at these symptoms of Cushing syndrome. Personality changes. Sometimes they get really angry or irate. It's just like they can cause them an irritability. Hyperglycemia. Okay, that should make sense as far as increased corticosteroids, increased glucocorticoids is going to cause high blood sugar. Increased mineralocorticoid is going to cause sodium water retention. So they have high blood sugars. Told you the CNS irritability, which can give them some kind of a mood change, moon face, fluid retention, edema. Their little arms and legs get skinny, like I said, because the fat gets redeposited. GI distress, their skin gets very thin, and you can start seeing some stretch marks and striae on them. Females can start getting amenorrhea and hirsutism, especially when with large doses. I said thin skin, and then because of the thin skin, they get bruises, petechiae. Osteoporosis, it thins the bone. Okay, the longer they're on it, it thins the bone, and they're at very much of a risk for an increased fracture. Buffalo hump, fat deposits in the trunk area. So guys can have gynecomastia. They may get a little bit of fluid retention in their breast area. They're immunosuppressed because that's what the corticosteroid does, decreases the immune system to decrease inflammation, right? Inflammation is part of our immune system. That's a natural defense mechanism for when our immune system works. Inflammation, all the mast cells and all the different cells in response to inflammation. So when we give somebody a corticosteroid, it suppresses their immune system, so hence they're susceptible to infection. Lab work, very important to know. It should make sense to you that you're going to see high sodiums in these patients. If we're dealing with aldosterone and somebody has an increased sodium, then the body is going to decrease potassium in relationship to that high sodium because aldosterone is increasing. As aldosterone increases, sodium increases, so potassium has to decrease, okay? So hypernatremia and hypokalemia with aldosterone. Hyperglycemia, they become more insulin resistant. We talked about that. Diagnosis can be difficult. A history and physical cortisol tests from blood, urine, and saliva, and you will learn a little bit more about the cortisol test. So I don't really want to go into it. Just recognize that that is how we diagnose it. Depends on the cause as far as treatments. If there's tumors, obviously we're going to remove them. Discontinue medication if we can. Some COPD patients can't breathe if they're not on prednisone. Some severe asthmatic patients can't breathe if they're not on prednisone. And sometimes they just have to stay on it, but we want to just decrease it. We want to discontinue it. We want to give them the least amount of dosage of corticosteroid with the best result. Manage their blood pressure, they're hypertensive, manage their potassium, their hypokalemia, and manage their blood sugars, they're hyperglycemic. Addison's disease is the total opposite, a deficiency of adrenal cortex, hormones, glucocorticoids, mineralocorticoids, and androgens. Okay, so the androgens are the sex hormones, and that's why somebody with Cushing, sometimes women, they get hair, they get hair on their body because of the androgens that are increased because of that overstimulation of the adrenal gland. This is a deficiency. Their adrenal gland's not working. They're not over secreting these adrenal cortex hormones. They're under secreting them. Remember, adrenal glands are right here on top of the kidneys. Keep that in mind when patients go into kidney failure because of a low blood volume, hypotension. Their adrenal glands get affected too, and they go into adrenal insufficiencies in the ICUs, often because of that. Causes, it's rare. Autoimmune condition. We typically see it in women more than men. Typically around the age of 30 to 60 years old, but it can come at any time, but those are the most common ages. So autoimmune deficiency is probably the main reason, but there can be some other reasons: tumors, pituitary dysfunction, a result of an insufficient ACTH that actually stimulates from the pituitary to the adrenal gland right here. And this is our girl right here. So clinical manifestation, sorry, this should be a parenthesis right here. So let's think about these, okay? Now, we have a decrease in corticosteroids, so they are going to have hyponatremia. They don't have a lot of mineralocorticoids. They don't have a lot of aldosterone. They don't have a lot of glucocorticoids. They don't have the cortisone, okay? So they're hyponatremia, hyperkalemia, okay? Hypotension, they don't have a lot of sodium and water, so they're kind of are dehydrated and causing them to be hypotensive. No glucocorticoids, so they are hypoglycemic, just this total opposite of what we just said. We diagnose them with an H&P, serum hormone levels. We want to get cortisol, ACTH, androgens, see where the problem is coming from. Is it coming from the hypothalamus? Is it coming from the pituitary? Is it coming from the adrenal glands? Glucose levels, blood chemistry, adrenal and pituitary CAT scan and biopsy may be needed to figure out what's going on. Treatment, somebody with Addison's disease is going to get glucocorticoid and mineralocorticoid replacement therapy. You don't need to remember that dose, but know that they get treatment for the rest of their life if they have Addison's disease. If they have an adrenal insufficiency because of a hospitalization and their kidneys just got hypoperfused and their adrenal glands got hypoperfused, sometimes that's fine. They'll kind of bounce back. But if they have an Addison's disease, they do need a lifetime replacement of the glucocorticoid and mineralocorticoid, wear a medical alert bracelet, so if something happens, people know what their history is, carry extra medication all the time so the levels don't get low, and you can see some of the symptoms right here. So they get sometimes this bronze pigmentation, and it's not often as even as this. They get like kind of brown and white spots due to an alteration in pigmentation in their skin. So that's something a little different. We talked about the skin changes in somebody with Cushing's. They have skin changes in with Addison's too, and it is just that overpigmentation in certain areas. Changes in distribution in body hair, that could happen because of the lack of androgens. Hypocalcemia, postural hypotension. See, she's got a blood pressure cuff on. We just talked about that. Skinny and weight loss. They're weak. Could have some GI disturbances in both of them. Adrenal crisis. Sometimes they go into an adrenal crisis in the ICU, like I said, from multifactorial but often hypoperfusion of the adrenal glands. Profound fatigue, dehydration, vascular collapse. Their blood pressure just gets so low. Kidneys shut down. Sodium low, potassium high. Okay? And that is it. Thank you.